We are live. Okay. Good day, everyone. It's a pleasure to meet all of you here. We are on our 26th session of Learning Basic Arthroscopy series of lectures. Today we have a special lecture which is not exactly surgical oriented, but which is something every other orthopedic surgeon or a sports surgeon has to watch or learn, which is return to sports after knee injury. We are not going to be very specific about the ACL today. We want to cover most of the principles behind most of the knee injuries. So we have Dr. Alvaro Zamorano from Chile. He is, let me please share my screen. Okay. Dr. Alvaro Zamorano is knee arthroscopy surgeon from Chile at University of Chile Clinical Hospital, Santiago, Chile. Okay, and we also have a senior sports physiotherapist, Mr. Earnest Vijay. He is a fitness and rehab director and celebrity physiotherapist, and he's a director at O2 Studio, which is quite popular in Chennai, and he's also involved with VB Cricket Academy. Welcome, Dr. Alvaro and Mr. Ernest. Thank you for accepting to share your knowledge with us today.
My pleasure, sir.
My pleasure, sir. My pleasure.
Okay. And we have Dr. Srinivas Kambhampati. He is my senior colleague, knee surgeon from Vijay from Sri Datri Center, and myself, Dr. Saseendar, shoulder and knee arthroscopy surgeon from Apollo Hospital, Muscat. Over to Dr. Alvaro.
Thank you.
Please share your screen, sir.
Yeah, I will share. Are you hearing me well? Yep.
Yes.
Perfect. So thank you, Saseendar, for the invitation. I'm pretty excited to give this lecture. It's about return to sport after knee injury. It's my vision or my group vision. So this is my disclosures, but in this lecture, I now have a conflict of interest. My lecture topics is gonna be a general assessment. I'm gonna do a difference between pro and amateurs athletes. I'm gonna share you our and recommendation about ACL, meniscal surgery, and osteotomies. I picked these three aspects because are two quite different, but it has a lot of things I can share with you. It's a picture from my window in the Andes Mountain couple days ago. When we talk about the surgical objectives, we have to promoting early range of motion. For us, it's important to have a stable knee. Appropriate surgery, it's gonna be our aim, and complete and careful preventive planning. It's gonna give us that kind of outcomes. In terms of technical issues, we have to prepare good tunnels, good graft fixation, stable meniscal repair, etc. Those things, it's gonna give us appropriate surgery, avoid extra soft tissue damage to get some balance between the damage we have to do in the surgery process, but we have to be balanced in the extra procedures like lateral extra articular tenodesis. We have to be meticulous with the harvesting of graft, or we have to plan our big surgery like multi-ligament surgeries. And the last thing is give to the patient a stable construct that supports cyclical movements, and in terms of let the graft or the tissue in the position to heal. At the first visit and post-operative, for us, it's really important to keep in mind and to put our eyes on early correction for complete full extension. For us, it's really important to get full extension at the beginning, as well as full patellar mobility, and always it's important to give a swelling control and always promote muscle activation. And important thing is the quadriceps. And then it's time, and enough time, yeah, because we have to let the biological process to complete. So we have to get settled down. You have to give some education. We have to pull the gauge and pull the brakes, and not to rush, because biological healing process, it's already known for everyone, and we have time for, as you see in the picture, it's a tendon. We start in 3 to months to heal, and the ligament graft maybe up to 2 years to complete heal. So we have to earn time for the biological process. It's complete. And how much time for earning time, like as surgeons or as physiotherapists, we have two variables to manage. And the variables for me important is the psychological, always being positive, and always said to the athletes or the patients, it's gonna be the return to sport as quickly, as safe as possible. So it's important to let this fact clear. And we will progress with a full range of motion, tolerated pain and strict swelling control. And as we know, the pain control is really important because the pain can delay. So we have to protect the tissue until biological healing, and to complete demands of the rehabilitation progress, and always maybe generate some objective tools to progress. And for us, the final clinical assessment have to balance in reality and ideally. Reality because some patients, for my patients, are not pro athletes, and maybe don't have a lot of capacity to get some fancy or sophisticated tests that in my country are expensive. So in our reality is good quadriceps symmetry, tight perimeter compression, strength, dynamic valgus control, that is a good and easy to achieve test, proprioception, core control, no effusion, no pain, and no residual laxity. And ideally for my pro athletes, we have isokinetic evaluation, hop test, landing platform, MRI, etc. MRI control is a hot topic for us. Sometimes it's, for me and the Moon group, is to retard patients, to push the brake. Maybe you can control the biological healing of the tissues as a ligamentization process or meniscal repair, or you can see some kind of indirect signs of repair, like swelling or bone bruise. So it's still developing, it's still debating, because it's not mandatory for every patient, but in our setting, we use the images to delay a patient who is pushing to return early. And as I told you before, we have two different realities to face, and adaptation is mandatory. For amateurs patients, the healthcare providers just cover surgery sometimes, a couple of rehabilitation sessions. The patient are pushing to return to work, and the time is gonna share between family recovery. So maybe that real life, it's not the same for pro athletes. That's are my my professional soccer team, and we have 1, 2, 3, 4 physiotherapists, 1 masotherapist, and all of the infrastructure for them and to recover. As you see in my face, that player it's recently twist his right knee and lateral pain in the knee, and tell me when can I back to the pitch. So it's gonna be tough because he has a meniscal tear. It's gonna be a couple of months, but always the pro athletes are pushing us to gain days or to come back early. So our rehabilitation in pro athletes has these 5 stages. The first one is protection, then endurance, strength, power, and return to play. Every step are objectivized with a clinical examination and a couple of biomechanical tests. And in non-pro athletes, it's the same, but I can add the physical pain control and swelling in the first because maybe we can put in that specific topic our efforts at the beginning. So if we can give the patients at the beginning physical pain control and swelling, maybe the coming stages it's going to be easier for the patients to return to sport as soon as possible. And always we add pain control and the readaptation of daily living activities and work. This is my protection chart at the 1, 2, or 3 weeks on the first month, and for the surgeries that I made, ACL simple, IUC, maybe no partial with bearing, and for ACL complex with suture or something else, maybe use a hinge knee brace. So after that, we can show that flow chart to the patient to understand how many months it's incoming. So I will talk now about these surgical procedures at the more specific. For the ACL reconstruction, we have surgical objectives, and we have to perform a complete evaluation, not only ACL turn, and we have to close all windows. So make a good evaluation of residual laxity. Maybe it's going to be necessary some anterolateral procedures. Maybe at the clinical assessment, you have to figure it out if we have other ligaments involved. And always discharge meniscal injuries like cramp lesions or bucket handle tears, lateral root, or radial tears that we have to stabilize. And always we have to achieve a solid graft fixation in a topical position to give the more natural anatomy for that patient. And for me, it's important maintain the biological ambience to with remnant preservation and at the end determine the safe range of motion. For us, it's super important to see the knee at movement, and when the knee is stable, we can give that patient maybe 0 to 90 degrees of motion. What is the current status of reconstruction of ACL? We have a lot of information from recognized groups to return at the same level, 40 or 55, achieve that. Always, it's not so at the same level as before, 2 technical levels below average. And in elite soccer players, we have more successful rates at 93%. But the re-injury rate, it's maybe with return to sport criteria, 4.5% within 2 years, and we have 1/3 of our patients within 2 years that they not achieve return to sport re-injury rate. So it's really big, and higher rates of re-injury when the patient returns early at that 9 months, and the psychological response is also important. What's gonna happen if after my anterior cruciate ligament reconstruction? Return to sport, 80. I told to my patient 80%. Risk of revision or contralateral side, it's already 4 to 10%, increasing in younger population. Post-operative knee osteoarthritis is always a risk, and the risk of total knee arthroplasty, it's well known. So we have to avoid awareness of the knee, and maybe the most important thing is self-confidence, optimism, and self-motivation. We have to take in account a specific population in younger athletes, and we have a high incidence of secondary ACL tear. 1 of 4, it's gonna be in the return to play period, and if we compare with the control group, we have 30 to 40 times greater risk to re-injury. So to have in consideration, we have anterior cruciate ligament reconstruction with meniscal surgery. We maybe meniscal repair with the ACL, less anterior joint laxity, and reparation rate of about 13%. And when we have meniscectomy, we have better symptoms, but we have more anterior laxity. So when we perform an anatomic ACL reconstruction, we are going to face that kind of failure rate with 23 in anatomic and 43 in non-anatomic. So our principles are similar to that publication, to give the ambient to the knee to heal. To rehabilitation is gradual, as is progressive in range of motion. We have to apply a lot of criteria and always maintain a core and proprioception stimulus. There is return to sport guidelines, but there is optimal criteria still remain elusive. It's not predictable, and non-practical guidelines to have we have to apply to all the patients. So some important thing is the psychological factors. Maybe it's gonna be more focused. When we talk about return to sport testing, the battery test did not significantly reduce the risk for further knee or specifically ACL. And when we pass return to sport test, we decrease the risk of rupture in 60%, but we increase the risk for contralateral ACL injury by 200% almost. Our protocol in amateurs is time independent, no jog before third months. If we have an ACL plus, maybe plus meniscal injury or something like that, 6 months with MRI, dynamic valgus test in all patients, young patient maybe 12 months, and maybe regularly for us is 8 to 10 months. In professionals, it's time variable, dynamic valgus test every 2 months. At the 6 month isokinetic test, triple hop test, platform MRI, and maybe we are closing to 6 months. This is one of the Chilean hockey selection girl. She turned his ACL and she complete all the test that I told you. In meniscal repair, Our surgical object is repair, give some biological ambient, solid construct, and allows early range of motion in impartial weight bearing and impartial meniscectomy. Sorry, we have to be economic in the excision of tissue and protects around cartilage and fat tissue like HOFA. Rehabilitation following meniscal repair, it's weight bearing and tolerance, early range of motion. We have biomechanical data that support that. And there is a lot of consensus. More studies are needed to give some more information. And return to play after following meniscal surgery, and meniscectomy is faster. We can provide in-session return to sport for athletes. Meniscal repair, always in younger athletic active patients, are accelerated rehabilitation protocols equivalent to functional outcome when compared with traditional regimens. And the meniscal allograft, maybe it's useful in salvage procedures, but return to sport is maybe sometimes not the indication. Return to sport after meniscectomy, most players within 7 to 9 weeks, repair 90% at the most at maybe 6 months, and return to sport after meniscal allograft is that rate. For us, meniscal repair is time variable, safe early roam, a range of motion, no weight bearing in roots or radial tears, weight bearing as tolerated in other patterns. There is no internal rotation, allows it 3 weeks, no squat with weight until 4 months, and jogging maybe into 3 or 4 months. Maybe 5 to 6 months and return to sport. And meniscectomy is really predictable, full range of motion always, full weight bearing as tolerated, and maybe in 2 or 3 months we have. This is our professional goalkeeper, and we are maybe at the 3 months after this meniscal repair, he is jogging now. And finally, osteotomies, we know that it's improved biomechanics, improves better gait, and there is a return to sport activity after osteotomies, more than 80, 82 or 85% at the 10 to 22 weeks and return to work and low impact sports. There is a role in osteotomy in athletes, yes, maybe it's more clinical cases. In our protocol, surgery dependent, no hinge problem, because if you see that hinge fracture, maybe gonna delay our protocols. Consolidation is dependent, time to heal. If the patient have to jog before 4 months, it's not allowed. Full range of motion at the beginning, and after consolidation, maybe we have to think in hardware removal to get all the patients to his activities. So the take-home message for us is pro athletes versus amateurs is different. We have to use a multidisciplinary approach. There is no kitchen recipe to return to sport. And after any surgery, support psychologically. It's always important to be positive, complete a minimum of parameters, and objective parameters are images, isokinetic test, biomechanical test, and we have to produce our own return to sport battery test. Thank you.
Thank you very much, Dr. It was a very crisp and lively presentation, and you covered a majority of the injuries, including the ACL, partial meniscectomy, and meniscal repair. As usual, I just want to recapitulate a few points that you discussed about. It is very, very important to make sure the stability is good. Whether it's an ACL reconstruction, then the joint should be stable, or if it's a meniscal repair, then the repair should be stable. Without stability, we cannot proceed strongly with any kind of rehabilitation protocol. And with respect to further rehab, it starts with swelling management or the pain or spasm, and subsequently, what is more important is to achieve the full extension. Flexion, it is quite easier to achieve, but if you lose the extension, then it's going to be hell forever. then make sure your patellar instability, patellar stability is maintained, patellar tracking is maintained, because a lot of times it happens that you don't concentrate much on the patella. You just keep your minds on the knee or the tibiofemoral joint. Then and the patella start. There can be some kind of a chondromalacia, even if you overstress the patellofemoral joint, or if you're not giving adequate rehab to the patellofemoral joint, then there can be some subluxation, and again there can be some chondromalacia or anterior knee pain. So that is something that has to be very, very closely monitored. Thank you very much for pointing all of them. And I think regarding the endurance, strength, power, etc., Mr. Ernest will be the best person to talk about. We are waiting for that talk. And it is very, very interesting to note down the statistics you pointed out with respect to return to sports, re-injury on the same side, re-injury on the opposite. It's very, very surprising or shocking to see that the report return to sports training or stress testing has shown higher rate of injury on the contralateral ACL.
Yeah,
So that's
yeah,
something
absolutely.
that's interesting or shocking. Okay, and the role of psychology, sports psychology, cannot be underestimated in bringing the athlete back to sports. That's very, very important. And osteotomies, I guess the indications for osteotomies are very narrow, but provided there is a deformity, I think they have to be very well considered rather than just achieving stability. We need to achieve the biomechanics. That is also very, very important. Thank you for pointing it out. We would like to have a couple of questions, but later after Mr. Ernest proceeds with his talk. So over to Mr. Ernest. Please go ahead with your screen share.
Thank you, Dr. Saseendar, for the nice introduction in the beginning. And to take it from where Dr. Alvaro has left, he covered beautifully the different aspects, how different stages of rehab is proceeding. So I'll be jumping on to the end stage of rehab, because that's what we are looking at when we talk about return to sports. And as we know, this is a very important topic, and it is a hot topic in today's scenario. Return to sports, everybody is talking about it because of the re-injuries that are pretty common in the knee especially, and also the revision surgeries are not as great as the one which we do as a primary repair. So it is a very important topic to start from where Dr. Alvaro has left, and he outlined the nice statistics which are coming out with the re-injuries and the contralateral injuries. And what do you mean by return to play? Return to play is having the full medical clearance to go ahead and do everything the athlete wants to do. So that is whether it is your strength and conditioning session, or it is your practice sessions, or your competition. So having the near normal, if not normal, ability to go back to the sport that the athlete is a part of. Right, and as Dr. Alvaro pointed out, previous injury is associated with up to a fourfold increase in the risk of re-injury. What do we mean by that? So somebody with a previous history of ACL tear or meniscus tear, there is always a chance of re-injury going to happen, because the neuromuscular system is not going to be optimum even after several rehab, or even after a good rehab. So there's always a chance of re-injury. And post ACL reconstruction, there is even more a risk of re-injury, and many do not return to previous performance levels. There is a dip in their performance level. Either they take a little lesser role in the team, and they don't. The peak performance is a problem. So as Dr. Alvaro had already pointed out, there is little original RTP research, and there is no standardization, and it can be a source of confusion to the sports medicine team between the sports surgeon, between the coaches, the strength and conditioning coach, between the physical therapist. So there can be a lot of confusion because no standardization is yet achieved. Right. And like Dr. Alvaro spoke to us, we have to weigh the risks and the benefits, and the athlete has to be told about what he can expect after the reconstruction. And taking the reconstruction is the main thing, although there can be an overuse injury which can happen in the knee, like the patellofemoral pain or the patellar tendinopathy. So we'll stick to the ACL part of the end stage rehab. So 90% of the professional players, what do we mean by that? The elite players or the players who playing at the top league levels are able to go back to their peak performance after 12 months. Whereas the general population or amateurs or recreational, only about 44% are able to return to competitive sport. And as we know that one of the complications of having a ACL tear, whether you manage it surgically or non-surgically, is the osteoarthritis. So which also is a risk which has to be told to the athlete what to expect um, out of the surgery or out of the rehab. Right. The past history of ACL reconstruction is the strongest risk factor for a new ACL injury, whether it is the injured leg or the uninjured leg, like Dr. Alvaro pointed out earlier. Most of them have a shorter careers post ACL injury because they're not able to go back to their peak level of performance, whether it's basketball or football. There is a shortcoming, and we have to look at women as a separate population because of the anatomy, the wider pelvis, and the valgus angle that puts on to the knee. So post the end stage of rehab, they have to undergo a lot of conditioning before they get back to sport, and there has to be a special emphasis on the dynamic valgus or the valgus load that falls on the knee and how to counter it. Uh, the neuromuscular factors also play a role because you need to work on the hip external rotators. So because of the wider pelvis again, so to counter the valgus stress that can fall on the knee. Hormonal difference also plays a role in women. So they are a special population that we have to look at when you're considering return to play. And Dr. Alvaro pointed out about tissue healing. Every tissue has a different healing time. We have to appreciate that, whether you're dealing with a patellofemoral pain or a patellar tendinopathy or a quadriceps tendinopathy or a meniscus tear or a meniscus repair. So they have a different healing time. It's important to understand and appreciate the healing time, the biological healing times when you're doing your considering your rehab. And you have to also take into different consideration when it comes to healing the systemic and the local factors which can affect tissue healing. And in the process of returning to sport, your first priority is to make sure the injured tissues heal without any trouble. So what we do is a protective healing stage. We do the rehab exercises keeping in mind the graft that has been put in place or the repair that has been done. So you need to condition the muscle without hurting the repair what the surgeon has done. So that is your first priority when you start your rehab. And then once you know the healing time is completed or the biological fixation is completed or the revascularization is set, then you look at preparing the tissue for return to function. And in the end stage, you do a proper rehab and reconditioning. I'll call it as a prehab. What you do in a prehab to prevent injuries is something which you need to do post your clinical rehab. So there has to be an on-field rehab that has to go on before you clear the athlete to return to sports. Like I told you earlier, the first thing is you have to make sure there is an optimal loading. That's what I will tell. Optimal loading is, so you'll give the right amount of stress, which is not too much or not too less for the tissues, keeping in mind the tissues that are affected and how they react to the stress that is falling on the knee, whether there is too much anterior translation force or a posterior translation force or a valgus load or varus load. You need to keep that into consideration when you're doing your rehab. So controlled therapeutic stress is what is needed to optimize the collagen matrix formation. You have to do overloading. Without overloading, the tissues are not going to get stronger, but it has to be an optimal overload. And specific objectives to be met in each phase before you set on to the next phase. So just to summarize what Dr. Alvaro has already spoken about. So whether you're talking about a patellofemoral pain or a patellar tendinopathy or a ACL repair, you have to follow a certain system. Yes, there may be an overuse injury and this is an acute injury, but you need to know where to do what and when to progress. So remodeling phase is what is critical when you talk about return to sports, right? Your job is to make sure there is optimization of the tissue function. Uh, your neuromuscular system is firing well, so the proprioceptors are at its peak performance. So if there is any perturbation that happens, they are quick enough to react. So you have to work on maximizing the GPOs, that is the Golgi tendon organs, and the capsular receptors, so that the proprioception is at its peak. And the closed kinetic chain and the open kinetic chain exercises have to be started, because muscle strength and muscle endurance are of maximum importance. We'll be discussing in the coming slides why it is important. So, and another important thing is you have to know what the sports demands. For example, if there is an IPL game of cricket and it's going to be a power which is mostly going to be exhibited, so then you need to know this athlete has to train to that level of fitness or to that level of strength. So there is a three-stage model when we talk about return to play. First, you evaluate whether the athlete is fit enough to get back to sport. And then you evaluate the pros and cons. What is the participation risk? And the third one is your decision modification. So we're going to deal about it. We'll look at it in the coming slides. So when we talk about the evaluation of the health status, we call something called as a baseline testing, which they have to satisfy before we take them to the next stage. So the first stage should be you have to be completely pain-free. The effusion should be bare minimum or not there at all. You should have got full range of motion, and you should not have any instability in your joint or in your function. And weight bearing should be comfortable. That's the first criteria. And you will do your clinical stress test if it is needed, and you will do a muscle strength and endurance. It's not that every athlete has to be put through an isokinetic testing. They can do a manual muscle test, or they can do a handheld dynamometer test just to document where they stay. If the biological healing has happened, it won't be a bad idea to do a 10RM test and to document the strength, and to make a note of different milestones that you achieve at different timeline. Right. So proprioception is another thing which you need to check. It can be, you don't have to really put them on a biomechanical ankle platform system. You can just make them stand on a single leg and see how they're balancing, how their vestibular, the ocular, and the peripheral proprioceptors are functioning. You need to optimize that. And if everything is satisfactory, you can also check for power. Right. So Dr. Alvaro had already mentioned about MRI, just to see the healing status and what is the tissue, how the tissue is lying inside, and if any blood investigation is needed is also done at this site. So once you have cleared the clinical stress are negative, right, and you tested the muscle strength and endurance, you tested for some proprioception, you tested a bit of power, like power can be a double leg jump. You need not have to load it single leg, but you can do a vertical jump test with the both leg, right? So the first having satisfied the first criteria, you do the second test, second criteria, and then you need to go to a functional movement screening, right? So what we are ideally looking at is the function and the sports specificity, how this athlete is going to move, right? So this is a small little tool that you can use to screen your athlete before you take them to the next stage of rehab. Right. This is a deep squat, what you see in the first slide, where the athlete has to go all the way down. Yes, you will take into consideration if there is a meniscus repair that has happened, right? Provided there is no biological restriction for your rehab, then you'll do a deep squat to see how functionally they are able to do, how stable are they, how the knee is looking, and how the trunk alignment is it in line with the tibia. Same way with the hurdle step, you check the mobility of the swing leg and the stability of the stance leg. So this gives you two feedbacks about the swing leg and the stance leg. So you will alternate and check how the athlete is able to do. So this again is an inline lunge. So this will tell you whether there is any valgus strain that is happening, whether the knee is able to go in line with the front heel, right? And if there is any valgus stress, or if they're not having any core control or stability, we can find out through this. And this one is a mobility test just to check the entire posterior chain of the lower limb, especially the hamstring tightness. And this one is called as a stability push-up. This is done to check the core stability. So what is important is, like Dr. Alvaro said, you have to focus on core strengthening when you are in the protective phase itself, right? And you have to strengthen your hip muscles without hurting your knee joint or without hurting the repair that you've done. The trunk stability push-up is again to check whether your core stability is achieved. The last one is a birdie dog, which where the athlete was taking his one hand up and one leg off. Right. Once you've satisfied that criteria, you need to do a battery of sports fitness tests, which are needed for that particular sport the athlete is competing with, whether it is a shuttle badminton or whether they're doing a team sport like a football or hockey. So you have different battery of tests that you need to do. So agility, speed, power, speed endurance, power endurance, dynamic balance, reaction time, the coordination, right? All these have to be tested. So the yo-yo test is something which you do for your endurance, right? Or you do a deep test for endurance, like that. So depending on the sport that the athlete is in, then you modify the test that you have to administer. Right, and the skill tests are sport-specific tests. Like for example, somebody is into football, then you have a box drill or different type of assessment that you do based on the sport that you are associated with. Right, and sports training and non-competitive. Once you cleared all this, then the sports training and the non-competitive warm-up games are practiced. And whenever you have a data to compare with, and most of the sports physios will be having a pre-participation data. Like before the injury happened, they have assessed, they have done all this battery of tests that you see here and the previous screen what you saw. They will be having a pre-participation or a pre-injury status. So it will be always better to compare with the data that you already have, especially when you're dealing with elite athletes. So you know that in the off season there was some assessment was done, and you can always compare with that. And as Dr. Alvaro rightly said, psychosocial evaluation is very important. The patient-reported outcome measures are also important. So that gives them a big confidence on what they are able to achieve functionally, and they're able to self-evaluate. This is a simple slide that you see for an agility test that we do, a T test. This is a 40-yard dash that is to check for speed. This is a Y balance test where the athlete is moving the leg in front to the right lateral and across. And this is simple agility testing, or you do a sports-specific testing. So what you do for your athletes. So talking about the most important thing is the RTS battery that we spoke about. Yes, all the assessment what you did earlier is typically done by any sports physiotherapist for any when they are with the team. So when you're dealing with somebody with the ACL reconstruction or coming out of a surgery, you have to make sure all these criteria are satisfied. The first one is a landing error scoring system. We'll be seeing the picture. I'll be explaining that to you. You have to make sure the score is less than 5. So the landing error scoring system is not only to check the quantity of the movement, that is not only to measure how much they're able to jump or leap. It is also about to see the quality of the movement, right? It is important that we check the quality of the movement, just not quantify what they're able to produce. And the limb symmetry index, that is, you have to compare the right or the affected leg and the non-affected leg for different hop tests. You have a side hop, you have a triple hop, you have a single leg hop, right? So you have to check those, and you have to also do a single leg vertical jump test to check and strength and compare with the other leg, right? So if you have a previous data is well and good, but if you don't have a previous data, then you need to compare with the normative leg. So unfortunately, the normative leg also takes a pounding after any surgery because there will be some kind of weakness. So you never know what the real strength of the athlete was, right? So the next one you look at is if you have an isokinetic testing, then you have to do an isokinetic strength evaluation and compare the quadriceps and the hamstring strength at different speeds between the right and the left leg. And you'll ideally like to have 90% of the strength of the non-injured leg on the injured leg. Right, and the next most important one is the hamstring and the quadriceps ratio, which is very important for the interplay and the stability of the knee. So for women, you expect a 55% ratio, that is the quadriceps will be comparatively stronger. If quadriceps is about 100 kg one arm, your hamstring will be about 55 kg one arm. So the ratio is also important to prevent further injuries or to predict future injuries. Right, this is a PROMS, that is a patient-reported outcome measure. You have a ACL return to sports after injury questionnaire, and you also have an IKBC questionnaire which you need to administer to see how they are progressing, because this plays a major psychological role in the athlete's mindset, and it is one of the major tools that you need to start using when you're looking at return to sport. So this is a landing error scoring system. You see how the athlete leaps forward like a long jump, and then they do a vertical jump. So you need to check the quality of the movement. It is a 1 feet box. From there, they jump forward. The forward, there is a marking which is about half the height of the athlete. Right? So when they jump, you see how they land. You see whether there is any valgus stress, what is happening in the ankle, what is happening in the trunk, is the hip going down, or there is rest mobility on the hip, is the knee pushed forwards, right? What is the angle on the knee when they land? Where do they land? Do they land on the toe or do they land on the heel? All these have to be checked, right? So this is an important predictor, and it has given a scoring, right? And this is a single leg hop distance test and a triple hop distance test that you do to compare with the non-injured leg. And this is a side hop test that you do for a 30-second duration. You'll check between the right and the left leg. Right, this is a vertical hop, single leg vertical hop you do to see how high you're able to clear the surface. You have softwares for it. You have a mobile app as well to check what is the vertical leap or the power that they're able to generate on the leg. Right, these are isokinetic testing, which I'll not go much into detail. Right, coming to the last few slides. So once you've done the evaluation of the various health fitness factor, now we need to look at the participation risk. So what is the type of the sport the athlete is playing? Is it a contact sport or non-contact sport? It can be a non-contact sport and still they can hurt their knee. Right? And whether it's an impact sport, is it a high impact sport, something like a basketball, where they have to jump and land, or a volleyball, or a skiing, right? So you need to take all this into consideration before deciding whether this athlete can go back to this particular sport, or do they have maximum risk where they have to choose something else, right? An alternative sport, right? Another thing what you can look at is the position played, right? For example, it might be a tennis player, singles player, right? Maybe this is the second time they got their revision surgery done, or you think there is a high risk of this athlete getting injured again, so you need to ask them to do a doubles, switch over to a doubles game, right? Limb dominance also plays a major role, because the leap or the jump, whether you're a triathlete or a sprinter, comes from the dominant leg, so you have to know which leg is actually affected. Next is the competitive level. Like I spoke about it a little earlier, like somebody who cannot be pushed to a high impact, high intensity sport, like an IPL game or like a T20 game. So they can be moved to a test match cricket, or they can be moved to a one-day cricket. So you can change the competitive level based on your risk evaluation. Right, and you have to also see whether this sport allows them to protect their leg, whether they can be taped in the knee, whether they can have a protective brace. So you need to evaluate all that before you decide on your return to play. So decision modification is another thing. What time your athlete is getting injured, is in the off season or in season, right? So do they have enough time to recover and go back? And setting realistic goals is also very important. Right, and you have to decide whether you want to make the player play in the league matches, or you want to keep them for the knockout matches, right? So as a coach and as a team, as a sports medicine team player, you need to take a decision. There is always going to be a pressure from the player and the coach to allow you to get you back to the game. So you have to resist that, and you have to always weigh the pros and cons, because there's one area where the sports medicine specialist has to take the decision for the player. So you need to make sure that you take the right decision. And change of roles, like most of the players, like once they become veterans, they become coaches or mentors, right? So you need to look at that as well based on what you see. That you should also be aware that they'll be masking their injury. They might be taking painkillers, or they're taking a steroid shot, which will be masking the injury. So you need to keep that into consideration. You cannot go by how they perform in the test, because they might have been using masking agents. And the fear of litigation is also a major factor for sports medicine specialists. You see in the BCCI pulling up the physios for allowing players when they are not 100% fit, right? So the fear of losing the job is also quite large. So what is the lacuna in the RTT training, or the end stage training, or the on-field training, what we call about? We as sports medicine specialists, we have to have the confidence to progress the athlete, just not think about the graft. Yes, the biological healing is complete. We cannot keep on protecting them because these guys have to do something which a normal person cannot do. So you have to motivate them to train on explosive neuromuscular performance. You have to check the quality of the movement, and most importantly, most of the athletes, they get injured towards the end of the game. Like for example, the 40-minute session, the injuries happen towards the end of the session because the fatigue sets in. The muscles are not firing enough. The neuromuscular system is not to its 100%. The proprioceptors are not great. So before you decide to return to play, you have to make sure you test in a fatigue state, right? And lack of sports-specific training is another major drawback in our country or most countries where on-field rehab is not done effectively or efficiently. As I told you, there is a set principle that you have to follow specific adaptation to impose demands. So you have to make sure the overload principle is applied throughout the rehab period. The lack of focus on the sport-specific fitness is also another important thing. Whether you're a fast bowler, you have to have a different level of fitness. Um, if you're a footballer and you're the forward, then you need to have a different level of fitness, power, and stamina. Right. Just to cut this one short, so we know what kind of injuries, I mean, Dr. Alvaro already underlined it, so I will not go into it. Psychological factors, return to play before 9 months, how it can have, uh, bad consequences. Right. So what we know is, right, better jump landing position, hop performance have a greater likelihood for the return to sport, right? But the chance of second injury cannot be identified using a RPS battery. So uh, we cannot rely whether it can prevent another injury, but it will help you to clear the athlete to go back to the sport. Right. So what we have to do, there should be a, like Dr. Alvaro mentioned, if there is a meniscus repair, then we need to have a clarity on when the weight bearing can start, because the longer we delay the weight bearing, it's going to affect the return to sports as well. And what are the range of motion restriction? Most of the time, we're not allowed to do a full squat till about 6 months time, whereas the athlete has a time frame. The season is there, so we have to work around it. Timing or criteria to start open kinetic chain quadriceps exercise is also important when we can start. Still, there is a lacuna in it. So hopefully, like with further researches, we'll get to know uh, how we can start. As of now, we do a 90 to 60 range without causing much of a translation to the graft in the um, repair phase of the rehab. Multi-component test batteries are recommended because, as I told you, you have to check the agility, speed, power, you have to check proprioception, you have to check all the dimensions of the sport. So when you decide on the return to play. Most importantly, movement quality has to be examined. Most of the time, we get to see the scoring, we get to see the numbers, but we don't know what was the quality of the movement. That has to be checked. Fatigue factor, right, like I mentioned earlier, you have to take that into consideration. You need to optimize the late stage rehabilitation or the end stage rehabilitation, which we don't we don't really are keen on. We know this athlete is able to do certain things, then it's left to the coach to do. So we have to make sure that the athlete satisfies all the RTS criteria and does all that is needed to be sports fit. Right. And most importantly, prevention is the key. So the FIFA has already started 11 plus programs. So preventing knee injuries is the key. So strengthening, rehabbing them should be given highest priority. So once there is an injury, the athlete is very, very rarely goes back to their full potential of peak performance. Thank you so much for having me, and thank you to all of you for your patient hearing. Thank you.
Thank you very much, Mr. Arun. You can stop sharing your screen.
Yeah.
Yeah. Thank you very much for the wonderful presentation. You touched upon all the technical details of what is to be considered with respect to return to play or return to sports. The re-injury rates after ACL surgery or ACL injury, and the parameter that have to be considered with respect to return to sports, with respect to, for example, women have a higher rate of re-injury and all that. And it was very interesting to know all the scoring systems. that are very useful in assessing the quality of rehabilitation and to assess whether the athlete is fit enough to return to sports. I have a question regarding the hamstring to quadriceps ratio, so I will go on to that soon.
Yes, yes.
And there are other parameters that also decide whether a person has a higher risk of injury even before he proceeds on to surgery, and possibly re-injury, especially the type of sport, the position in which he plays, the limb dominance, the competition level, ability to protect himself, and all that. Thank you very much. They are a very important recapitulation. Sports surgeon has to know a lot of these things in order to, because the patient is definitely going to question the surgeon. When can I go back to sports? He should be able to communicate with his physiotherapist or make sure the athlete or the patient has a very good quality rehabilitation. For that, the surgeon also has to know a lot of these things. Thank you for pointing them out.
Thank you, sir.
And your recommendations were very useful. I do agree that there is a lot of gray area over there. Lot of I mean, we are trying to understand a lot of things. We are nowhere near to ideality. There are a lot of things that are need to be known regarding rehabilitation, starting all the way from immediately after surgery. That is like weight bearing, and there's a lot of change in consensus whether still closed chain exercises alone have to be done or open kinetic chain has to be can be started with certain precautions. And thank you very much for your illustration with respect to the movement, the quality of movement rather than the movement. Okay, thank you very much. That was a wonderful presentation. And we will have the discussion for both of you. To start with, Dr. Alvaro, you were talking about accelerated rehabilitation program. Can you tell us more about it, and what do you want to differentiate it from with respect when you say accelerated rehabilitation program? What do you mean? You want to differentiate from a slower rehab program that was being followed earlier?
I think it's accelerate rehabilitation program. It's regularly the common rehabilitation programs for everyone. Maybe it's not it's not different that we are doing nowadays. So maybe strictly speaking, it's a prompt to put time before objectives, and maybe for me or my group or my knowledge, it's not so safe. So I prefer to stay step by step, and as early as the patient tolerate, and always seeing swelling and the pain and range of motion as early as possible. But I think it's our accelerate rehabilitation program. It's the regular basis for almost everyone.
Yeah. So Ernest, you'd like to add something to this? What is with
Yes,
respect to, I'm sorry, do you directly deal with post-operative patients or mostly for the?
we do. I was working in a
Yeah.
knee specialty initially of the part of my career. So what we see is when there is a rehab is delayed, we see a lot of arthrofibrosis and the muscle wasting. Sometimes the athlete is so fearful of the movement, they don't even want to bend the knee because they're so scared. And second is there is no confidence in them because they already had a couple of bucklings before the surgery has happened. And not many of them would have had a proper rehab before the surgery was done. So for most of them, it is the first time they're trying to move something or trying to contract something. So there's a lot of apprehension in them. So like Dr. Alvaro suggested, getting them to move them. Like you may not be, for example, if you're on a long leg brace, you may not actually be concerned about the knee. You can start moving your ankle, you can start moving your, start strengthening your hip, start doing your core work. Just for an athlete, every time you waste is precious. For example, the knee might be ready, but their general fitness may not have come back to what what the sports needs actually. So what we call it is a protective rest, or we call it as a relative rest. That is, you rest the knee, but you start working on all the other muscles, like including the other limb muscle, your upper limb muscle, your core muscles, so that there is some crossover firing which can also come in and help the injured leg. When you strengthen the good leg, so there is a crossover effect which can happen through the neuromuscular crossover. So it is important that we start the rehab early, keeping the biological healing in mind, and see how quickly we can get them back.
Yeah, Dr. Alvaro, you wanted to say something?
Yeah, it's I remember something about I think it's early rehabilitation program, maybe, or accelerated rehabilitation program. For me, on my physiotherapist group, it's always mandatory. But I have patients that they don't came for to my multidisciplinary group, so they have to go other physiotherapist, and maybe that kind of situation can be not so good for patients. I do always maybe for biological aspect or construct, biological construct in meniscal repair. I commonly open repair. I do a lot of stitches. I put a lot of strength in my reconstruction. And if my physiotherapist doesn't understand what is I do, maybe arthropfibrosis is gonna be regular. So I have couple of patients that they don't came to my physiotherapist and came back for me to me at 2 or 3 months with 0 and 30 degrees of, come on, it's not good. It's not good. It's that why the physiotherapist has to understand how what it's will what was my surgery and my objectives. So if I allow to move 0 to 90, I expect to have in 2 or 3 months or more than that. It's a I want to point it out, that thing.
Yes, Dr. Sassi, like you said, it's a teamwork. So the physio has to understand what the surgeon has done, so they can complement each other well. And I think that the more studies, if they can happen if you can see more studies which can, if they can come up and allow a bit of early mobilization, I think it will save a lot of trouble, because end of the day, the athlete is committing for surgery or for the intervention so that they can go back to do what they want to do. So as a team, we have to make sure that they realize that goal. So so that is something which more and more research. I'm sure it will come in, because things have changed a lot in the last 20 years. I'm sure we'll have better things coming up as well.
Yep.
Okay, so to summarize, I think I can say that the accelerated rehabilitation program is not something like totally different from something what is done previously. The rehabilitation has been changing over time. Our understanding of the surgery, our understanding of the fixation methods, our understanding of absolute anatomical fixation, and obviously our understanding of the rehabilitation protocol. What is right, what is wrong, what could be in between, and how we can prevent further injuries has been changing over time, step by step. So finally, I think what we do right now is definitely an accelerated rehab program, but it's not specifically, we don't have a specific method we are comparing with. On the other hand, it's very, very important that the surgeon is very confident about his fixation, the anatomy of the fixation, the stability of the fixation, and it cannot be underestimated that there has to be an automatic understanding between the surgeon and the physical therapist. All the more, it is also it's very, very good to even have regular meetings, if not direct patient exposure or patient contact by the physical therapist along with the surgeon in the form of grand rounds or something like that. It's very good to understand what the surgeon is thinking and understand for the surgeon what the physiotherapist is thinking, so they can actually have a very mutual discussion as to what each other feel is safe or not safe with respect to specific diagnosis preoperatively, specific situations of individual patients preoperatively, and specific surgical procedures, and the way in which the surgical procedure is done by that particular surgeon. For example, the ACL done by Dr. Alvaro can be way different from what I do, and the rehab protocol may have to vary quite differently. On the other hand, I think we are moving on to less and less bracing and more of weight bearing or isometric strengthening or range of motion exercises in a graded way, all the way from day one after the surgery, provided we have already worked on the basics of cooling down the knee, avoiding flexion deformity, and avoiding effusion and all that. I think that sort of explains this particular topic. Is that right, Dr. Alvaro and Mr. Ernest?
Yeah, you're right.
Yeah, wonderful. And with respect to one particular point, which Mr. Ernest, you pointed out, with respect to hamstring versus quadriceps, hamstring is to quadriceps ratio, I don't want to call you being very what do you say, uh, against women, but on the other side, you showed that the ratio is more than 55% for women and more than 62.5% for men. Why the difference? I just want to understand the scientific basis for that.
For women, is more the valgus and the varus, the valgus strain that we are looking at. So we will rather look at the abductor ratio to the adductor ratio with women because of the valgus over dominance. Second is the muscle is a two joint muscle. The hamstring is a two joint muscle, and given the pelvis origin and the attachment, it starts at a wider one and comes in. So the muscle is at a disadvantage for women. So obviously you cannot expect the same amount of alignment or the biomechanical alignment what you see in a man. So there is a subtle difference when it comes to women, but it's very important that we check the abductor and the external rotator strength also in women.
Okay, that's very interesting to know about. I mean, this is all new for me. So you're more concerned about targeting the adductor and abductor strength also in women, and in addition to the hamstring versus quadriceps ratio. Okay, so I'm going to talk about something which I have already raised with Mr. Ernest in a different meeting. Okay, so Dr. Alvaro, the question to you is: after a hamstring graft harvest, do you specifically want to delay the hamstring strengthening or rehabilitation for a while, and how long would that be?
No. For me, when I use hamstrings, there is no concern about delay. I think in my patients, and commonly they tolerate more efficiently than BTB graft. So they are commonly more prone to move, and the strength is regularly growing up, and no, I don't have any concern about that. I think there is data by that supports that, and the 7 to 8 months, maybe we can compare both hamstring strength, and it's the same. So for me, it's going to be part of the process. At the beginning, more conservative because of pain, but at the end, I stimulate the knee flexion as pain as possible.
Okay, so other than the pain factor, you don't specifically block or delay hamstring strengthening just because you harvested
Yeah.
the semitendinosus aggressive graft. Mr. Ernest, your opinions?
The question is the one because you've taken a hamstring graft, did you delay the hamstring strengthening? Is that what you had mentioned, right, sir?
Yeah. Do you specifically like to delay the rehab on the hamstring side
Hamstring.
just because you have harvested a hamstring? The surgeon has harvested a hamstring graft.
Yeah. So we all know that when you harvest, there is a bit of a strength deficit in the areas that you harvested. Whether the tendon has been, I mean, the hamstring graft is taken, then you always have a little bit of a deficit in the hamstring. So we know that it affects it indirectly. I mean, so we know there is some kind of an effect that happens later. So if there is any soft tissue injury that has happened, I'll look at it as like a soft tissue trauma and give it at least 2 to 3 weeks before I go aggressively strengthening it. And I'll personally be guided by the pain. If they're having pain on the posterolateral aspect of the knee or where the graft has been harvested, then I'll know not to activate that part of the hamstring. I'll go a little slow. Maybe you'll go with a gentle isometrics with 25% effort, right? And then push it to 40% effort, right? So depending on what I see with the patient, what the patient is telling us, then we'll go based on that. But overall, I look at it not to go aggressively because sometimes we see some patients having pain on the posterolateral corner of the knee post the ACL reconstruction. So I tend to take it easily, at least for the first 2 3 weeks, and then slowly take it up. So look at it like a soft tissue injury.
Okay, so you want to point out that when you tend to strengthen the hamstring, there can be overactivity in the posterolateral, group of muscles. So the patient, it can be counterproductive for the patient. Is that right?
Yeah, the
Okay.
pain can be a inhibiting factor for them. So
Okay.
don't
So
want to
basic.
provoke.
Okay. So you basically want to slow it down, but not actually stop the activation
Exactly.
of the
Yeah, yeah.
hamstring. Yeah. Yeah.
You're right. You're right.
Yeah. Yeah. Okay. So that is
Maybe,
something. Yeah, please.
maybe in the experienced guys that carrying out the physiotherapy of the initial rehabilitation program, maybe it's a good point to take in account. But as I told you to my patients at the beginning, it's gonna be as a big muscle tear. So is that why we have some pain, some swelling, some and obviously we have less strength than the other side. But if you follow the principle of not as pain as possible, maybe you can avoid a lot of problems. But if you are going to rush, maybe you can give to the patients maybe posterolateral corner because the over stimulation of the bicep femoris, maybe.
Okay. So I raise this because a lot of times I see people totally stop hamstring strengthening, want to rest the hamstring absolutely for a couple of weeks, which I'm not sure whether the right thing to do because the semitendin. A lot of times we harvest only the semitendinosus, and there are a lot of other posterior muscles that are able to do the job, and we don't want to let them get wasted or weak over time. So thank you for pointing them out. I carry the same opinion. I don't want to stop the hamstring strengthening, but as Mr. Ernest said, it's good to go with a goal of a percentage of the hamstring strength rather than expect 100% stimulation of the muscles straight away. So that's a very good discussion. And there are a couple of questions with respect to this particular question. Mr. Vijay Kaliswaran, he has asked when exactly you want to start the hamstring strengthening.
Okay, so for example, like that, there is a different protocol for different surgeons. If I'm allowed to do start a little bit of a heel slide, right, and without the knee brace, it will be as good as the second day, or whenever the surgeon is allowing me to do the movement. So it can be as simple as doing a heel slide, which can activate the muscle where the heel is supported. There is less work that the hamstring has to do. So as early as the second day, and after the heel slide, maybe I'll start with a the heel digging, which is that static hamstring exercise where I ask the patient to press the heel down onto the floor gently with about say 10% effort, 20% effort. You can always use the good leg to compare, ask them to mimic it on the good leg and ask them to experience what a 10% or a 25% is, and then ask them to copy it on the affected leg. So that way, you know that the athlete is or the patient is not putting too much effort than what you want them to do.
Yeah, very good. Alvaro.
Yes, I assume that we are talking about ACL reconstruction,
Yeah.
because we are the hamstring, it's avoid or inhibit in PCL reconstruction or
Yes.
post-lateral corner reconstruction.
Yeah.
So
Yeah. I'm sorry. We were talking about ACL reconstruction. Thank you for pointing it out. We don't want to specifically over activate the hamstring in the after a PCL reconstruction. Similar to you don't want to do an open kinetic chain exercise for an ACL reconstruction. Thank you for pointing that out. And Dr. Alvaro, there is a question from Kamlesh Jain. What is your opinion on large synthetic graft for ACL? Is it associated with an earlier return to play when compared to the other grafts?
yes, I know that information, but I'm 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 the guy that my opinion is to wait a lot of more information going up, but synthetic graft for me is I have to be careful with that. Maybe it's a gain. It's a good movement for early days, but at the end, finally, we have failure rates, iterated failure rates. So maybe we have to settle down sometimes. But I don't use synthetic graft. I do perform a couple of ACLs repair in young guys. And I told to the patient and the family that the failure rate it's going up, it's growing. It's worse than the ACL reconstruction, but we only have the ability to make an ACL reconstruction if we fail with the repair. But with the synthetic graft, for me, it's a big question.
Okay. So, Earnest, you have something to say about this?
I think I've not come across any synthetic graft as yet, but all we know through the literature is it is always a foreign body, and we don't know how it's going to respond. And there has also been a lot of talk about the cadaveric graft that is being put inside, like the allograft, is it? I mean, if I'm right. So we also know about, we don't know about how it is going to stabilize or how it's going to hold. So, but the autografts have the best possibility of integrating well because you take it from your own tissues. And so that way it also gives you a confidence as a physio when you know that what kind of graft that is put in, whether it's a BTB or you put a hamstring autograft or allograft. And once you talk to the surgeon and based on how confident they've been with the fixation and based on the go ahead, so you can plan your routine. But synthetic graft, like Dr. Alvaro said, is a gray area and we don't know how it will respond. And we don't want to take the chance with an athlete unless the athlete has done the revisions 3-4 times and you don't want to harvest and weaken the tendon or the muscles. So where you're looking at as a last option.
Yeah. Okay. With respect to evidence on synthetic grafts, I think there's more and more evidence stating that the synthetic grafts are possibly better than autograft. The studies are. I know one study that is coming from China, but with respect to as far as the stability is concerned, yes, possibly it could be a good step because there's not much of possibly not as much of healing that is needed. But with respect to proprioception, that is something that we need to be worried about. We can't expect an equivalent proprioception. That's what I guess, but we need to look into more and more results, long-term results of this thing from future. Dr. Srinivas, you want to go with your questions?
Thank you very much, Dr. Alvaro and Mr. Earnest. There have been excellent presentations and discussion. From the point of view of, say, an early ACL surgeon and the patient, they have a few questions that are very common, actually. One is, when do they go back to some activities? So things like, especially in India, squatting, going back to motorbikes, using motorbikes, car driving. What, in your experience, say after an isolated ACL reconstruction, in your experience, what are the timings? Do you go on a time-based time scale, or is it based on goals achieved?
I think it's a very nice question, Dr. Srinivas. Like, as I told you, my first objective is to make sure the swelling is down and the range of motion is full. I will rather try to achieve at least about 100% range of motion, or at least 80 to 90% range of motion like the other leg by the 8th week. So without any force, I'm looking at an active range of motion. So for that, I need to have started early because I don't want any arthrofibrosis to have settled down and the effusion should have gone. So a lot of the times we make a mistake that the joint is stiff, but actually it is the effusion that is preventing the range of motion. So addressing the effusion, bringing it down is very important. And as a physio, when you're working with a post-op ACL, sometimes if your exercise intensity is little more, or if you're given too often, the frequency or the load is too often, the repetitions or the sets, then the joint reacts. So you have a effusion the next day. You know that what you've done the previous day is little too much. So you cut down, you go back on the intensity or the load, wait for it to settle down, and then you take it again slowly. So ideally 2 months is a period I will look at, because if I'm right, I think that's also the biological fixation time where if it is a BTB to get integrated into the bone. So once I get the full range of motion, then I will slowly start doing some functional activity, allow them to use a two-wheeler or a four-wheeler after consulting with the surgeon, of course. But usually that's a good time frame to look at. 8 weeks is a good time frame. It doesn't happen the timelines are always not perfect. For some patients may take about 10 weeks to get full range of motion. Some will may be able to get it in 6 weeks itself. Especially I've seen it in people who've done a good prehab where they had full range of motion, no joint effusion before they went to the surgeon. So they seem to come out well post-operatively. But 2 months is the timeline I will look at before allowing them to for more activity.
Alvaro?
Yeah, yes. Maybe ACL, simple ACL reconstruction. It's for me pretty straightforward procedure, and I allow my patients go maybe early with bearing, with the use of crutches. So I always concern about meniscal repair and the surround tissue rather than ACL reconstruction. So if we use stitches or we repair a root, maybe that patient is going to be a lot of precautions, and we are not allowed to internal rotation. Maybe we are not allowed to weight bearing as a tolerate. Maybe we are going down. So a simple ACL reconstruction for me, it's 2 weeks with 2 crutches. The 3rd week I allow the patient to drive. And for me, it's important to get over the bicycle as soon as possible to get full range of motion. And if we are adding more surgeries or more procedures, maybe we are point the brake in the rehab or the allowing things to do. So I prefer to going patient by patient, telling them which this is going to do that way, or you have to avoid that the other things. And maybe the birth weight, in squats with the weight. Maybe it's for me in 4th month after ACL with the meniscal repair. If you are talking or asking me about jogging, I'm really believer that jogging early it's worse than before. So I prefer to stay away from jogging. So I delay 3 to 4 months. I think that jog doesn't add nothing to the rehabilitation process. So and always add maybe some degree of inconsistency with the proprioception. So I prefer to delay, and that are my concerns.
Mr. Ernest,
Yes, sir.
on average, how many sessions do you take for ACL rehabilitation, and what frequency it's usually?
That's again another good question, sir. So initially, if we see a quadriceps inhibition where we need to do a VMO stimulation, then I like to see them 5 days a week initially. But they're able to have good volitional control. They're able to contract the quadriceps and they're able to activate the patella using the quadriceps. Then I don't have to see them every day. I just see them 3 times a week in the first 2 weeks. And after that, it's about 2 times a week. Give them a home exercise program and come back to me. But I like to follow them up till 4 months. It might be on a lesser frequency. It might be once a week. Then later I progress to once in 2 weeks. So they're given a program to work on and then come back to you. And in some athletes, I make sure I follow up till they get back to sport. So till the end stage of rehab is completed, since we have a sports fitness background, so we have a good facility where we can train them in the end stage of rehab, whether it's plyometrics or whether doing high-end strength training, and then we make sure that they're ready for the sport when they go on. So usually, if it is a normal lay person, it's about 2 to 3 months is the time we follow up. But if it is an athlete, it goes up to 6 months. So sometimes till about 8 months, but usually up to 6 months. By then they know what is expected. They need to be working with a strength and conditioning coach or a fitness trainer, not with a physio by then.
So on average, how many sessions do you think they have to attend?
Okay, so it depends on an average. I will say at least about 40 sessions. At least for I'm looking at a 6-month period. So you need at least about 40 sessions of rehab if you're seeing them sporadically.
When you see a patient, you know yourself that this patient is going to do well. This patient may not be able to do well. What are the pointers for you to say that this patient is going to do very well? He'll recover very fast. He'll go back to sport very fast. And some patients, you know that this patient is not going to do well. What are the pointers in your experience?
It is again a good question, sir. So 2 things: we always have a good coper and a bad coper, and for the athlete, one thing I personally feel is they have to see some progression. Otherwise, athlete for any patient, so if they're going to be stuck in the same range, they're going to be stuck in the same functional activity that they were doing, they're not going to be motivated to come to you or to follow through the protocol and see through the end of it. So when you look at somebody who's a good coper and a bad coper, even before the surgery, somebody who has a less frequent buckling, somebody who has a strong lower limb strength, and somebody who's not going to be playing a pivoting sport, right? And somebody who's a highly motivated, this patient will adhere to the rehab program. They will do the rehabilitation or whatever you plan for them, they will do, and they have a less risk-taking behavior. I know they'll be a good coper. So they will not. I know they will not be taking risk which they will buckle down or anything. So I can safely tell them, you can wait and watch. You do the rehab, avoid 1, 2, 3 because that is not their primary goal as well. They never wanted to do any pivoting sport. So they'll be able to jog, they'll be able to cycle, anything unidirectional. They're good. They're happy with it. They're able to swim. So the patient is confident and comfortable with what he's able to achieve. So you know that this patient will do well when you're looking at non-operative thing. So post-operatively, one of the objectives for me, whether the patient will do well, is the mental strength plays a major role. How important it is for them to get back to what they want to do. swelling is another major factor. So if the swelling is receding fast, that means it gives me a confidence that I can push them a little more, activate the muscles, I can stimulate the muscles. So when this patient starts seeing progress and they're not seeing any regression, so it is very important during a rehab session, you have very less regressions. That is, you cannot have a session where it was too much and there was inflammation, the patient is not happy. Then again, you go back by one step and then again you build it up again. So you have to make sure that you're marked properly. So the mental strength, swelling, and adherence to the exercise is something which is a good predictor that this guy will do really well. And another thing I want to do is about the risk-taking attitude. Most of the young athletes or young kids, so they don't understand the graft has to be protected for about 2 months. They cannot do pivoting activities. They'll be jumping when they are going out of the clinic. So you have to educate them. Patient education is very important. And I usually give them a stick I'll tell them you take a stick when you're going out, because people use public transport sometimes, they go to malls. So when you have a stick, at least the other person will know that you have an injured leg and they won't rush you or push you. So some simple tips and techniques will help them help them in the journey of recovery.
So now, for me, it's mental strength.
Yeah.
Nothing but if the patient understand that they have a problem, it's gonna be healed as soon as possible. If he has or she has mental strength, we are nothing better than that.
One last question to both of you, actually. Which sporting athlete do you think are difficult to manage and they get back to sport later? Among all the sports, which one did you find the best to go back to sport and recover, and the worst to go back to sport and recover?
For me, the more anxiety patients are doing bad. We have to control anxiety and pain, because those kind of patients have anxiety and pain and are worried about everything. Maybe those think of patients, independent which sport they practice.
So you don't think it's related to sport?
Yeah, it's not related to sport. I have a couple of younger professional athletes that in every sport that I work in: soccer, hockey, karate, taekwondo. If those guys are mentally prepared, and where they are going to do well. But if those guys are anxiety, has a lot of precautions, the family is really overprotecting them, maybe those guys is going to be slow and maybe complicated. And for me, a complete different population is younger patients. My focus now is to prevent re-tears or prevent problems with those kind of those guys, because as you said, those guys are unpredictable. Maybe you can educate a lot, you can maybe give some lectures about it, and always do what they want to do. So I have a couple of guys that their family finding them playing soccer at 1 month after ACL reconstruction. So we say, come on, there is no understand about nothing. So I'm really concerned about that kind of population. I use a lot of brace on them. I use a lot of scratches, because I know that the time is gonna do this work, but I want to break them and always over protect.
Yes, sir. The major factor is, like Dr. Alvaro said, is the mind. The fear of re-injury is a major factor. So most of them hardly go back to what they were at their peak. So you know that the optimal performance is down. This guy is nowhere playing like what he was playing earlier, because it's never the same. It's never your original. It's always a reconstruction. So the fear of re-injury, to the fear that they'll get hurt again, fear of going through the whole process of 9 months plays in their mind. So that is a major detriment for them. Unless they're highly strong mentally and they want to do it, it's very unlikely. So most of the guys who are in the racket sports, non-contact sports, are safely go back because the demand on the knee is not as much as what you see in a sport like a kabaddi or a football or any contact sport for that matter, like a hockey. So the less impact non-contact sports, they're able to go back to, most of the time they're able to go back because the fear of re-injury is less, and uh, again the mental strength comes into play, like how badly you want to go back to the sport.
Any particular sport you found they take longer to recover?
Any spiking sports, like a volleyball, I because even 6-8 months they're not there 100%, but uh, they get re-injuries, effusions again. Even after 2 years follow-up, we see effusions. Any spiking sport, we see that. And most of the time, in 6 months, the coach wants the athlete to play, so they cannot. And it's a season for them. If they don't play that season, somebody else is going to take their place. So they don't mind compromising on the knee, but they want to be in, because even if there is an effusion, they want to do something else and they want to still play. So spiking sport takes a lot of time, and any pivoting sport for that matter. Football is something which I've seen that not many, they take a longer time and they not many go back to that aggressive level of playing. Or like Dr. Alvaro said, they use a brace and play in spite of having the knee surgery because of the fear factor that they have.
There are actually a couple of late questions. Do we have time to take those?
Yeah, go ahead, sir.
One is from some Nithya Selvam. Like she's asking, like muscle strengthening exercises, is there any specific ligament exercises? There is no answer till date. Please answer.
It's a good question. So you have to understand, especially at least with the extra-articular ligaments. So it is a connective tissue. Ligament is a connective tissue. The capsule is a connective tissue. And what science is telling us now is not, if it's a quadriceps muscle, only about 70% have a typical connection. Like it goes to the superior aspect of the patella, and the patella takes it through the tendon and inserts to the tibial tubercle. The remaining 30% of the muscle fibers are inserted into the fascia around the knee, which indirectly connects you to the ligaments. So if you want to strengthen your ligament or your tendon, strengthening the muscle is a way to deal with them, right? Because when you contract the muscle, the load is going to the ligament as well, right? I'm not sure how much it can help to strengthen the intra-articular ligaments, because I don't think that is possible. But the extra-articular ligaments, yes, like a lateral ankle sprain of the ankle, or a MCL injury of the knee, or a LCL injury of the knee, or a patellar tendinopathy. So the way to address them is by strengthening the muscle.
Dr. Alvaro, do you have any views on this?
Maybe
specific ligament exercises?
no, not that much.
One point I'd like to add is for the proprioception. So adding proprioceptive exercise will, will optimize the response time, the neuromuscular response time. So any ligament that you're dealing with, it's important that you add some balance training to your athlete.
Yeah, that's important. Proprioception, it's maybe you can measure proprioception with the delay on the in a situation that the patient falls and rebounds. Maybe it's a good point, but proprioception comes with time. So you cannot do. You have to stimulate the joint, but it's gonna be time, no more than this.
The other question is, do you consider any brace for professional players for graft protection?
I do use in as I told you, when we have more than ACLs, isolate ACL injuries. So I protect all the knee, but when we have ACLs isolated, I don't use brace, but I use brace in PCLs. I use brace in multi-leg knees. I use brace in knees and ACL plus meniscal repair for protection.
So one of the things is like Dr. Alvaro said, yes, for extra protection you can use it. So some sports it becomes like a target. For example, a kabaddi, the opponent knows that your leg is injured, and they'll start targeting you on that. Or for wrestling. So the best, I mean, in those kind of sports, your best bet is to strengthen your muscles and make it work like a brace. The brace might give you about 5 to 10% extra additional support. Somebody who's done a revision ACL reconstruction, yes, you need to look at having a brace because it is not going to be 100% stable for the athlete. So using external braces in those kind of situations will definitely help.
Absolutely. Absolutely agree.
Thank you very much. Thanks a lot for your answers.
Yeah, Mr. Earnest, I have one last question. The place where I am living and working around in the Gulf, where the cultural requirements are quite different, in addition to sports. So, in relation to that, can you advise as to when a person after ACL reconstruction can kneel down for prayer?
That's a good question. Like if you look at like a weight bearing point of view, it is only going to be a posterior translation. So I personally don't think it's going to make much of a difference with the graft integrity if it is a ACL reconstruction. So I will, if the swelling is gone, I don't mind making them do a complete prayer position even at the 6th week or 8th week, unless you have done a meniscus repair. So if the range of motion is full, there is no effusion, patient is comfortable doing it. So I personally don't have any reservation in helping them do it. Initially, what we do is we put a couple of pillows between the heel and the ankle so that there is a restricted range. We don't allow them to go for a full knee flexion. And moreover, the Vajrasan position or the prayer position is not a full weight bearing position like the Indian squat. So it is more like a partial weight bearing. It's not like where you're doing an Indian squat where there's a lot of force that is falling on the articular surface and on the ligament structures. So for me, if the range of motion is achieved, then I don't have a problem with that. I mean, it's going to be only a flexion that is happening there.
Dr. Alvaro, what do you think? When do you advise to squat for prayer, especially for a Muslim?
No, it's squats.
For a person who practices Islam.
Well, I don't have any experience on that, but
Okay.
always my I have couple patients that works in kneeling position, and in the construction, painting or something like that, and those guys, if I do BTB, complains about pain. Maybe 1 year, but I allow to use his knee to kneeling with a pillow. So those guys maybe are happy with that.
I think if you use a PTB, then it becomes difficult, isn't it? It takes longer.
Yeah. Yeah, so kneeling pain, it's 25% of the patients. And it's independent of your technical surgical technique. It's 125% for almost everyone. If you are not so delicate or not so meticulous, maybe it's higher. But in my patients are 25%.
Okay. Mr. Ernest, now regarding your opinion, actually, I have a bit of a concern over there. Yes, there is more of a posterior translation to the tibia rather than an anterior translation. That's a good thing. But when, yes, having a pillow will restrict the amount of flexion or weight that is going on to the knee. But at 6 weeks to 8 weeks, possibly the graft is at the ligamentization stage. In hyperflexion, you expect the anteromedial portion of the ACL to go into a lot of stretching. I'm not talking about a double bundle ACL reconstruction, but the extremes are where you have more stresses that are going through ACL. Personally, I would be concerned about allowing the patient to go on a squatting. What's your opinion about that?
Okay, you're the guy who's done the surgery, so you know it the best. So.
Okay,
So
fine.
for me,
Yeah,
that's how I think, as in the biomechanical sense. That's what.
Yeah. My concern is what I would like to say here is we need to be concerned about the stresses that are known to be higher in hyperflexion. That is like an anteromedial bundle is supposed to have a lot of stresses, and in extension, the posterolateral bundle is going to be in a lot of stress. So when you are trying to equalize both of them, at least a part of the graft will be stressed. So personally, I would give more time, at least 3 months, when I will allow them to squat with support with their hands. I mean, during the process of squatting, they can go into the squatting with support on their hand, and they can come out of the squatting with the support on the hand. In addition, as you suggested, the pillow and all that could be an additional. That's what I feel. Okay, I
input,
think it was a very, very lively discussion. It was wonderful. Thank you, Dr. Alvaro, for pointing out a lot of aspects of return to sports, and the pictures on the ground. They were awesome. Very good. And Mr. Earnest, thank you very much for a very lovely discussion. I think it would have helped a lot of physiotherapists and definitely sports surgeons also. Thank you very much. I hope to see you all soon again. Thank you, Dr. Srinivas.
Yes,
Thank you. Thank you, everyone. Have a nice day.
Bye.
Thank you.
Take care.
Thank you.
Bye-bye.
Thank you all. Thank you.
Bye.
Bye-bye.